Okay, so I think we're starting. Hopefully everybody can hear us. I'm privileged today to be joined by my new associate, Dr. Susan Maxwell, who's recently moved here from New York and is going to be able to chat with us a little bit about the subject at hand today, which is that of endometriosis, as this is, I believe, Endometriosis Awareness Month. So it's a timely subject for us. Dr. Maxwell is well versed in fertility as well as endometriosis. She is board certified as a fertility specialist and OBGYN and has extensive experience in treating and diagnosing endometriosis. So Dr. Maxwell is going to give us a little bit of an overview of what endometriosis is and how it may affect us. So, Susan, you all set?
Thank you, Dr. Surrey. So I'm joined today by Dr. Mark Surrey. He's one of the co-founders and medical director of Southern California Reproductive Center. He is also board certified in obstetrics and gynecology and reproductive endocrinology. He's a clinical professor in the Department of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. And he holds a bachelor's degree from the University of Pittsburgh and his MD from George Washington University. He did his internship and residency at UCLA Medical Center and a research fellowship in reproductive endocrinology and infertility at the University of London. Next slide. Next. So here at Southern California Reproductive Center, we have a long proven track record of more than 25 years of experience in infertility. We have 2 state-of-the-art embryology labs. The main location is in Beverly Hills, but we also have a lab in Santa Barbara. We have on-site surgery centers at both locations, and we also have a satellite office in Pasadena. What sets us apart is our premier laboratory facilities, our ART labs. And both laboratories have experienced and certified laboratory directors. We perform double witnessing verification for all patients. So we make sure that we are working with your eggs, embryos, or sperm exclusively. We use technologies such as vitrification, which is a flash freezing technique for sperm, eggs, and embryos. And it has superior outcomes when we do this flash freezing technique. We are very well experienced performing embryo biopsies at the blastocyst stage, which is the day 5 stage. And we have a lot of experience with pre-implantation genetic testing for both aneuploidy, which looks at all 24 chromosomes, or for single gene disorders. And we can also perform sex selection. We also have embryoscopes at both of our laboratories. An embryoscope is a device where we're able to culture embryos within it and take time-lapse videos of those embryos as they develop throughout the whole time. So this does lead to superior results, and we're able to go back and look at how they developed. So not all labs have access to that technology. Next. So today we are going to be discussing what is endometriosis, and then we'll go into patient testing, fertility treatment options, and our own success rates, and you can meet members of our team. At the end, we'll do a Q&A. Next slide. So as Dr. Surrey mentioned, this month is Endometriosis Awareness Month. And so we wanted to touch on what endometriosis is and what we can do about it. Endometriosis affects 1 in 10 women of reproductive years. And there is a general lack of awareness about endometriosis, which can result in a delay in diagnosis. And this can ultimately impact your fertility. Next slide. So what is endometriosis? So endometriosis is a condition where the glandular tissue, which usually is just found in the lining of the uterus, is also found in places that it's not supposed to be. So it can be found on the uterus itself, on the outside of the uterus, in the muscle of the uterus. It can be found on the surface of the ovaries, or even on the fallopian tubes. And this tissue responds similarly to hormone changes. So it will bleed when a patient gets their menstrual period. So this bleeding tissue that is not where it's supposed to be ends up causing a lot of pain and inflammation for the individual. Next slide. So how is endometriosis diagnosed? Well, the gold standard for definitively diagnosing endometriosis is with a surgery called a laparoscopy. And this is a procedure where a small camera is placed through the belly button so that we can visualize the inside of the abdomen. And we can see endometriosis growing on the surfaces of the abdomen or on the uterus, fallopian tubes, or ovaries. When we visualize the endometriosis, we can also stage the severity of it. Some cases of endometriosis are minor, but others can cause significant changes of the pelvic anatomy. There are also different protein markers or inflammatory markers that have been associated with endometriosis that can be performed either with a blood test or with an endometrial biopsy. These tests can suggest that endometriosis may be present, but they're not definitive like doing a surgery. The advantage of doing a surgery for endometriosis is that it can also be treated at the same time. So endometriosis can be removed from the pelvic surfaces, adhesions can be cut, and any abnormal structures such as cysts on the ovaries or abnormal fallopian tubes can be removed. Next slide. So how does endometriosis affect fertility? Well, it can significantly affect the ability of a woman to conceive. And this is mainly due to increased inflammation from this tissue being outside of the uterine cavity. The increased inflammation can affect egg quality and cause declines in egg quality, which can make the eggs harder to fertilize and also cause decreased embryo development. The inflammation can also affect the ability of an embryo to implant successfully in the uterus. And most importantly, endometriosis can cause distorted pelvic anatomy, such as scar tissue or blocked fallopian tubes, which can inhibit the egg's ability to travel from the ovary into the uterus for implantation or fertilization. So a lot of women who do have endometriosis, especially if it's moderate to severe cases, will require fertility treatments, especially in vitro fertilization, which Dr. Surrey will discuss shortly. Next slide. There are medical treatments available for endometriosis. However, these treatments typically address the pain associated with endometriosis. Common treatments are an oral contraceptive pills, which will prevent the buildup of this endometrial tissue and reduce inflammation. Progesterones also help with this. And other medications such as Lupron, which is an injection that stops the periods from occurring for a few months, can also decrease the inflammation from endometriosis for a period of time. Next slide. So when we are evaluating a patient who has infertility, and if we suspect endometriosis, we will do a thorough medical history and physical examination, and then we'll do a series of diagnostic tests. Next slide. Because endometriosis can affect ovarian reserve, we typically will check markers of ovarian reserve, such as an anti-Müllerian hormone level. This is a blood test, which gives us a sense of the number of remaining eggs in the ovaries. We also look at a hormone called an FSH, a follicle-stimulating hormone, and this hormone can be elevated in women whose egg pool is declining. And then finally, we do a pelvic ultrasound, and sometimes we can see cysts on the ovaries, which are caused by endometriosis. And we can also get a sense of ovarian reserve by counting the number of antral follicles or upcoming eggs on the ovaries. Next slide. In patients who have infertility, we also do an examination of the male partner, and this usually includes doing a semen analysis. And on the semen analysis, we're looking to see if the volume is normal of the sample, the concentration. We look at the movement of the sperm, and then we look at how the sperm are shaped. Studies indicate that 25% of infertility may be contributed to a male factor. Next slide. In patients who potentially have endometriosis or who are trying to conceive, we do recommend overall lifestyle modifications to help with this. Nutrition is very important, and vitamins and nutrients are linked to positive effects on fertility. We recommend healthy diets such as a Mediterranean diet with plant-based foods such as whole grains, vegetables, legumes, fruits, nuts, and seeds. Folic acid is an important supplement for having a healthy pregnancy. Folic acid can be found in your diet in legumes, asparagus, and dark leafy greens. Vitamin B12 is important. It can be found in organ meats such as liver, kidneys, clams, sardines, beef, and tuna. And omega-3 fatty acids are also healthy, which can be found in fish, chia, flax seeds, and walnuts. Next slide. The supplements we recommend for women who are trying to conceive is a prenatal vitamin. And the most important component of the prenatal is folic acid and vitamin B12. These are associated with improved fertility, live birth rates in IVF, and lower ovulatory infertility. CoQ10 is a supplement that is good for both men and women. It is a potent antioxidant, which has been associated with increased numbers of eggs retrieved, higher fertilization rate, and more high-quality embryos. And then vitamin D is important for reducing miscarriage rates and improving IVF pregnancy rates. Next slide. Avoiding toxins is very important when you are trying to conceive. Having more than 4 drinks of alcohol per week will decline IVF success rates and birth rates. Cannabis should be avoided for men and women. It is associated with poor IVF outcomes as well as lower sperm counts. And then tobacco is something that can cause small infants in pregnancy and also can reduce AMH and antral follicle counts and IVF success. Next slide. So now Dr. Mark Surrey will talk about some of the fertility treatments that can be beneficial for women who have endometriosis.
Thank you, Dr. Maxwell. That was a great summary of what's relevant in regard to the etiology and nature of the problem, it's magnified by the fact that as we age as human beings, our fertility significantly diminishes. And if you look at the monthly fertility rate for women, you can see that within the 30s and early 40s, it decreases significantly. And that seems to be related to the percentage of genetically normal eggs that we produce as human beings. So that the idea of having endometriosis delay our fertility is counterproductive and leads to a lot of issues which are in fact age-related. Next. So when we look at the natural ovarian aging process, it's pretty significant during puberty and ends at menopause, essentially, so that there are fewer eggs, and many of those eggs, as we see, are not going to be genetically normal. Next. So when we look at treatments, it's very common to see people asking for and having inseminations recommended, mostly because it does not require anything but natural fertility, which is what it is. But that's also the reason why it's not so effective in patients with problems such as a diminished ovarian function or endometriosis, because it essentially just injects unfertilized sperm into the uterus with the assumption that it will meet an egg and cause normal embryo development. Next. So the idea that Dr. Maxwell mentioned of IVF, or in vitro fertilization, is in point of fact going to have to be much more effective in treatment for many things, including endometriosis, because its efficacy is based upon the knowledge that some of the eggs that we produce are not going to create a pregnancy, so that by producing more, and this can be accomplished by taking stimulants. The stimulants are naturally occurring releasing factors that come from the pituitary gland called follicle stimulating and luteinizing hormone. And when a patient takes those, it's necessary to do monitoring of the response that you would have to that by ultrasounds and hormone levels, which are done usually a few times during, which will tell us exactly when the follicles that contain the eggs may be mature or be ready to be fertilized. Next. And at that time, the eggs can be retrieved transvaginally by ultrasound and inseminated with the sperm in a laboratory, hence the word in vitro fertilization. Next. So when you do this, you can inject individual normal sperm into each egg, and that allows us to create embryos even when there are very few sperm. And this is what it looks like under a microscope. The egg is actually one of the cells in the human body with more water than many other cells. And as such, it's very fragile and sensitive to things like manipulations. Next. So once you can do that, then it allows you to see embryo development, which you cannot see when you do inseminations. Embryo development occurs over the period of 5 to 7 days and consists of symmetrical cell divisions up to the point of what is called a blastocyst formation, which usually occurs after 5 or 6 days and consists of approximately 100 cells. It is at that stage when an embryo can implant and cause a pregnancy. And that's the reason why it's important that we create an environment in a laboratory that allows us to see this. So people who go to places where they do what are called cleavage stage transfers at 4 or 8 cells are not able to see this, and therefore they're not able to understand the normalcy of embryo development, which is critical to achieving a normal pregnancy. Next. So the EmbryoScope is something that you're seeing here, which is a video system underneath the incubation system, which shows us cell divisions. And this is gradually becoming a blastocyst, which looks like that. And it is at that stage that the embryo can implant. And prior to implantation, we encourage genetic testing of the embryo, which can be done without impacting the embryo viability at this stage as well. And that will allow us to know the normalcy of the embryo before it's used, which will allow you to achieve a much higher rate of a normal pregnancy and a much lower rate of miscarriage. Next. So when we look at the results, and ours are in the blue, we see that they are much higher than national results because of the technology that we've just spoken about allows us to examine and know which of the embryos you produce are going to be able to have a normal pregnancy result. Next. So we're very happy to speak to any of you about this or any other issue, but we wanted to make you aware of the technology that's available for people with IVF and with endometriosis who may benefit from things like IVF. And I'll give you just a very brief example of how things have changed over the last 20 years or so because of IVF technology. It used to be that a typical patient of ours who may be 38 with endometriosis would come in and start with a surgical process, which would then result over the period of the next year or two with normal fertility, which for a 38-year-old, as we know, is relatively low per month. Whereas with IVF, it's going to be relatively high in the area of around 75 to 80% per attempt. So IVF is an interesting technology that also happens to be a really valuable tool to have for patients who have endometriosis. So we're very happy to answer any questions that you guys might have at this time. And I think Dr. Maxwell is available as well. So Susan, do you want to see about answering some questions?
Yes. So question here is there any difference with starting stimulation during the luteal phase versus the follicular phase? So when you stimulate the ovaries, the purpose of the stimulation is to extract eggs, which we use then to create embryos. Typically, when we've done IVF, we've stimulated in the follicular phase so that if we needed to do a fresh embryo transfer, then the lining of the uterus would be timed appropriately with a transfer. Now, with our current way we practice IVF, we are doing a lot of testing of the embryos and they're getting frozen, and we are coming back in a different month to do the embryo transfer. So it's less important what is happening with the lining of the uterus, whether or not it's in the follicular phase or the luteal phase. We tend to more commonly stimulate in the follicular phase for IVF.
So the next question that I'm seeing here, is there any potential risk to the blastocyst if an embryoscope is used? And the answer would be no, in so much as that the embryoscope is what we call morphokinetic embryo analysis. It is not in any way invasive and allows us to observe embryo development. So there is no risk to the use of this kind of incubation system for your embryo. Mm-hmm. Susan, you want to answer Ashley's question? Is IUI an option for women with endometriosis?
So IUI could be an option if there was minimal disease from endometriosis. So women who have stage 1 or stage 2 endometriosis who potentially have that removed surgically may have the normal anatomy after the surgery and be candidates for an IUI procedure. However, if there's any scar tissue present or with more severe cases of endometriosis, more often IVF is the only successful treatment.
So there is another question about MRIs. Are there indicators of endometriosis that can be visualized from a pelvic MRI, which stands for a magnetic resonance image? And there can be, but mostly if they are space-occupying lesions, in that an MRI is a visualization of imaging of the pelvis. So it's not a tissue diagnosis per se. So the answer is sometimes.
So this next question is a good question. For those with endometriosis, is it better to undergo egg freezing before or after excision surgery of the endometriosis? So the answer is that it depends. Excision of endometriosis from the ovary will result in lower egg counts over time because some of the normal ovarian tissue does get disrupted when a cyst is removed from the ovary. So in women who have very low reserve and are found to have a cyst on the ovary, it's possible that your physician may recommend trying to stimulate with that cyst in place. Now, having a cyst on the ovaries can also make it more difficult to get eggs safely retrieved from that ovary. So in other cases, we may recommend removal of that cyst first before undergoing egg freezing. So it's really depends on the patient and it depends on their egg reserve characteristics, which is attempted first. Mm-hmm.
So Megan, you did your excisional procedure recently, and you're looking now at an egg retrieval cycle. And, you know, you're correct in that stimulants that stimulate your own estrogen hormone could, in effect, stimulate endometriosis. But were it to do so, it should not directly affect the number or the quality of the eggs that you make, but rather you should be downregulated before transfer. And we usually do this with a medication prior to the transfer, after the egg retrieval. Susan, one of our patients' question is about the fact that she has a low AMH and she is 45 and wants to know about how she should pursue things. You have thoughts about that?
So one of the most difficult things about women who are presenting really over the age of 42 for treatments is that egg quality has declined significantly. So egg numbers are important in order to be able to respond sufficiently to the IVF medications to get enough eggs out of the ovaries to work with to create embryos. But when egg quality is very low, then we can have difficulty with embryo development or having normal embryos when we test them genetically. Over the age of 42, fewer than 10% of embryos are genetically normal. And at 45, we very rarely see genetically normal embryos with IVF. So some patients who are over the age of 42 consider alternative treatments such as using donor eggs to conceive.
So is it possible to surgically remove tissue from stage 3 or 4 endometriosis, or just stage 1 or 2? The difference being that stage 3 or 4 endometriosis by definition involves endometriosis in the ovary itself. And it is possible to surgically remove that, and it may even suit you better than removing minimal endometriosis. But it is possible that after removal of advanced stage endometriosis, it might be recommended that prior to additional treatment that you take some suppressant medications afterwards to prepare you for additional treatment, whether that be in vitro fertilization or something else. So let's see, Susan, is there anything else that you'd like to sum up with?
I think, the last thing I think we should mention is that if you are somebody who has a diagnosis of endometriosis, because it can significantly impact your fertility, it's important to get regular fertility testing and consider freezing your eggs if you're not ready to conceive, because endometriosis typically worsens over time. And you can have premature lower egg numbers or loss of eggs at a faster rate if you do have a diagnosis of endometriosis. So I would encourage you to be proactive, get fertility testing, see what is going on, and pursue egg freezing if there are any concerns.
Good point. So I think that there may be another couple of thoughts that we should address. Susan, do you think AMH can increase if after some treatment?
So AMH can be impacted by suppression of the ovaries. So if you have been treating your endometriosis with suppression on birth control pills or Lupron, that will temporarily decrease that AMH value. And we would need you to come off of those medications for 1 to 2 months in order to get an accurate AMH level. So in that respect, the AMH can fluctuate with ovarian suppression. However, we are not able to create more eggs on the ovaries if they have in fact been lost over time.
So there's a lady who has had a cyst removal for endometriosis and then 3 cycles of IVF and 3 embryos frozen, one of which is mosaic, which means a little bit normal, and 1 genetically healthy embryo. And you're wondering what type of things might come up during transfers for people with endometriosis and how you might prepare for a transfer. And one of the things that we may suggest for you to do before a transfer under your situation would be to take some medical treatment for a time prior to the transfer, which may make the lining of the uterus more receptive to a transfer. And it may also be a good idea to take additional imaging with something called an MRI to look at related things in the uterus prior to a transfer, something called adenomyosis, which would be good to know about. Susan, you want to comment about why some doctors discourage surgery?
So the decision whether or not to operate on endometriosis depends on a patient's symptoms, if they're having significant pain or not. And it depends on the size of the disease. So if there's a cyst on the ovaries, if it's very small, we tend to observe that. Whereas if it was large, we might encourage removal. And also the location of the disease. So if the fallopian tube was damaged and there was something called a hydrosalpinx where it was blocked and dilated, that may be something that we encourage you to remove in order to improve your fertility. So it really depends on what is going on with the endometriosis and how extensive it is and where it is located.
Great. Well, thank you very much, Susan. It's been a pleasure to speak to everybody. And Dr. Maxwell and myself, as well as the other physicians here, will be more than happy to answer any questions that you guys may have about this or any related subject in the form of either a remote or in-person consultation, where we might be able to offer some ideas for your treatments. So, Susan, any other thoughts before we say goodnight to everybody?
No, but thank you, Dr. Surrey. And yes, I think if anyone would like more information, we'd be happy to speak to you during a consultation.
All right. Have a good evening, everybody. Watch the rain, and we'll look forward to seeing you sometime soon. Take care.
Bye-bye.